Knowing the signs and symptoms of heart disease and a heart attack can help save a life. Heart attacks are serious medical conditions. Therefore, it is important to learn the signs and symptoms of a heart attack. In today's program, Dr. L Saravanan, Director, Institute of Cardiac Sciences, Bangalore Baptist Hospital, will discuss how to be heart healthy. This will be a focus session on lifestyle modification to reduce risk of heart disease. This session will principally focus on diet, exercise, stopping smoking. In addition, we will also be discussing benefits of regular health checkups to identify risk factors for heart disease such as high blood pressure and diabetes and treat them effectively to avoid complications such as heart attack and stroke. Please listen to this program called Healthyliving every Tuesday at 8 a.m. and 8 p.m. on FEBA Online. If you have any questions and for more information, please write to us at info@febaonline.org or you can call or WhatsApp us to 916364252164. Thank you, Doctor, for joining us in Healthy Living program. Thank you so much. So, Doctor, what do you do when someone comes to you with a heart disease, heart stroke?
Yeah, that's a good question. As we discussed earlier, the sooner they come to us, the more helpful we can be to them. So if they come to us early in their illness, when they are getting some symptoms of chest pain but not yet had a heart attack, which is the stage we talked about as angina, and if they come to us at that stage, then I do some tests to confirm that it is angina. The common test I do is a test called a treadmill test. Okay. So I make somebody walk or briskly walk or gently jog on a treadmill, and then we take an ECG.
Okay.
When they are doing it, they are connected to the ECG and we are continuously monitoring it as they are running on the treadmill. So that we reproduce the symptom and we look at the ECG.
Okay.
That gives us an idea that is this or is this not a symptom of heart disease.
Okay.
Based on that, we go to the next step. So if it is due to heart disease, if it is angina, then we know that there will at least be one critical narrowing in the 3 arteries of the heart that we talked about.
Okay.
So how do we find out? So we go to the next stage called coronary angiogram. So that I do. Previously we used to do it from the leg. Now we do it from the wrist. It's a keyhole procedure. It's a very simple and a very low risk procedure to test for the block in the heart.
Okay.
So we give a local anesthetic in the wrist, put a plastic tube into the heart, and put some dye which is radio opaque, and take a video X-ray picture.
Okay.
So we move the camera around the heart, around the patient, and take the X-ray of the blood flow.
Yeah.
So when the dye does not flow, it causes a kind of constriction, a narrowing that we can see on the X-ray. So that is what is a narrowing about.
Okay.
So once we see the narrowing, if the narrowing is in one of the main arteries, and if it is more than 70% narrowing, if the lumen of the artery is 3 millimeters, if the area where it is narrow has become very close to 0.6 millimeters, that is more than 70%,
Okay.
at that point, we think it needs to be opened up.
Okay, so if it is more than 70% block, then you will suggest for an open heart surgery.
Suggest to release the block.
Okay.
Suggest to open the block.
Open the block.
Now, how do we open the block? There are 2 methods of opening the block. Increasingly, we do not recommend bypass surgery unless it's absolutely needed.
Okay.
Because a bypass surgery involves opening the chest, a big scar in the chest, the heart will be stopped, connected to a machine, and then they will be connecting various arteries to the heart. It is not without its risk, and it is something that has a long convalescence period. Not bad surgery, but there are much better alternatives. And the commonest alternative, and that thing which I do day in, day out, is putting a stent into the heart artery.
Okay.
We call that as coronary angioplasty. The term is angioplasty. Angio means arteries, plasty means reconstruction. So we reconstruct the narrowed artery.
Okay.
The way I do that is the same method from the wrist, same catheter that goes to the heart, but through that catheter, I'll put a very thin wire, which is 0.03 millimeter wire through the narrowing. I'll pass that wire through the narrowing. On top of the wire, I will railroad or push a balloon. And then stretch the narrowing, squash the narrowing. So the narrowing is caused by cholesterol.
Okay.
So that cholesterol will get squashed
Okay.
to the sides of the artery.
Okay.
If I release the balloon and leave it at that, it will regrow.
Okay.
So how do I prevent that from regrowing and reblocking? I put a stent in. A stent is a metal tube, which is like your mosquito net, a chicken mesh-like thing. It's a mesh which is made into a tube.
Okay.
So that tube is mounted on top of a balloon, and it's squashed. When it comes from the packet, when I open the packet, it's a thin tube. So I push that thing, locate it where the narrowing is, and then blow the balloon up. So the balloon will stretch the stent and stick it to the side of the artery.
Okay.
Now the artery is fully open. The inside of the artery has got this metal tube, which is preventing it from reblocking.
Okay. So how long it can sustain?
Good. Yeah, that's a very good question. A lot of people think that stents will get rusted. They do not. Okay. they are a metal, but they are very highly scientifically tested alloy. Okay. Usually they're polymers. They're made of polymers.
Okay.
And previously we used to have certain stents called bare metal stent, which was just simply metal stent. And what we realized is that metal and body react. So it's not a good idea to just stick a metal in and leave it there. So nowadays, almost all stents in the world have been replaced with something called drug-eluting stent, or DES. So what we do is we coat that stent with a layer of a drug, which will prevent the stent from getting reblocked, which will prevent the body from rejecting the stent, and the stent from getting reblocked. Slowly the drug goes off, but by the time the drug goes off, the stent has, the artery has grown on top of the stent and covered it nicely. So then it becomes a part of the body. We never remove a stent. Stents cannot be removed, even if you want to. So we never take a stent out. Okay. So a stent, hot stent, coronary stent, once it is put in, it stays there for life. Most of the time, if you are good with your diet, exercise, we'll come back to that later. Diet, exercise, regular medications, change your lifestyle, don't smoke, all of that. If you follow good medical advice, the stent will be open forever. It won't re-narrow. But if you don't do any of that, or if you have high risk factors, such as somebody who has got very bad diabetes and somebody who's got a very high cholesterol for some reason, then they can re-narrow. And the rate at which they re-narrow depends on how good somebody is with their diet and exercise and all that. Roughly 10 years is what I tell my patients. 10 years is a kind of reasonable guarantee we can give. There's no guarantee for anything in life. Okay, anything can happen for anyone. But 10 years is a reasonable time when one could expect the stent to be functional and not cause further trouble.
What is that further trouble when you say
good. Further trouble is re-narrowing of the stent. When it re-narrows and then reblocks, because, mind you, I have not fixed the root cause of the problem. I have just opened up the artery. So I have just fixed the cause of the effectively it is like I have given you Saridon or paracetamol for headache. I have not fixed the reason why you got it in the first place. So we need the only way to do that is medicines, diet, exercise, look after your diabetes, look after your blood pressure. Those are the ways in which you can prevent the re-narrowing, but it may still re-narrow. If it re-narrows, you will have recurrence of the same symptoms. The chest tightness, the sweatiness and all that. If you have that, then you need to have another test again. So first thing again, we go put them through the treadmill test, check if that is the cause. If it is the cause, we do another angiogram, check if there is a block, and I can re-stent the stented artery. I can put another stent into the stent and open it.
Again?
I can do it up to 3 times inside the same stent.
Only, at that particular area?
At the same point.
Otherwise, how many stents are suggested in different areas?
You can as many numbers as possible, but the more metal we put into the artery, the more, it is not great. It is not great because God gave us artery, and the artery is an elastic structure. The stent is a metal stiff structure, so it can't be the same.
So this is up to stent. and how it leads to an open heart?
Okay, so there are times when stenting is either not possible because the mechanical, say for example, I've recently, yesterday evening, I did an angiogram test in somebody with a similar situation, and I found that they have a block there, and five places.
Okay.
So I have to put 5 stents in one artery, or at least 3 stents, 3 different stents, or I can send them to a bypass surgeon, heart surgeon, who will open the chest and take one artery from the back of the chest or one vein from the leg, and they will connect it to the main artery, and then put the other end of that tubing to the end after all the block. So they bypass the block. That is why it is called bypass surgery. So if there are 5 blocks, they can still put it beyond the 5 blocks.
Okay.
So it is the same surgery. Where they put this depends upon where the block is.
Okay.
For me, it is a different thing. If there are 5 blocks, I have to put different size stents because this artery is smaller, that artery is bigger. So different size stents at different levels. So it will be 3 stents at least for that one artery.
Okay.
And the more narrowings there are, if there are more narrowings in all the 3 arteries, which is common in diabetes.
Okay.
If somebody has diabetes and heart disease, we will see multiple narrowings in multiple arteries.
Okay.
So it might end up being 6, 7, 8 stents needed, or have one bypass surgery.
Okay.
In that situation, I myself will say, look, I can do this, but it's not in your best interest.
Okay.
It is more risky, more expensive, less effective. Why do we want to do this? Stenting.
Okay.
So we go for a bypass surgery.
So it depends how many.
Yeah, indeed. It is depending upon the number and the nature of the block in the artery.
Yeah, that's good. So this is stent and bypass. Now we'll talk about pacemaker. So how is that? How does that work?
And a lot of people think pacemakers and heart attacks and stent and all of that is single disease. And I tell them that there are 2 different components. As we started off saying, the heart has a mechanical component, a blood flow component, plumbing component, and then the electrical component. So stenting, heart attack, that is plumbing. This is wiring.
Okay.
Pacemaker is wiring. So this is electrics.
Okay.
So then I suddenly, from being a plumber, I suddenly become an electrician. Okay, so I change my portfolio there. So I become an electrician. For the heart to beat in a sequential fashion, so that we get a lub, dub, top of the heart beats, bottom of the heart response, and so the blood flow is in a sequential fashion and it's doing very well. That is constituted and controlled by electrical wiring systems inside the heart.
Okay.
God gave it to us. It's amazing. Okay, I mean, He's amazing than any of us, right? And His creation is such that there is an area in the heart which you can't see with your naked eye, or even with any microscopes. It's very difficult to see that. But He put it in there, where on the right side, top of the heart suddenly generates an electrical impulse. That is what makes the heart keep beating all the time, round the clock. So that electrical impulse spreads through the heart in a nice sequential fashion, making the heart beat in a sequential way. When there is a block in the conduction of that electricity, or when that generator itself fails, we put a pacemaker.
Okay.
A pacemaker is a human, very inferior alternative to God-given electrical wiring of the heart, but we can rewire the heart using that. And we try, the pacemakers are increasingly becoming very clever. It's a mini computer.
Okay.
So what I do when I do a pacemaker is, when does somebody need a pacemaker? They need a pacemaker when their heart is slowing down and there is some electrical block in the heart.
Okay.
The common symptom of that, dizzy spells, lightheadedness, collapse episodes.
Okay.
So somebody is sitting in a church listening to a sermon, and the next thing you know, they're collapsed to the ground. The common reason, particularly in the elderly, is that the generator of the heart has failed.
Okay.
So therefore, they have a few missed heartbeats, no blood flow to the brain, they collapse.
Okay.
So in that circumstance, they come to us, we test, confirm that, and then treat with a pacemaker.
Pacemaker. Okay. So you suggest medicines also. So when they undergo heart surgery, bypass surgery, or stent or pacemaker, so most what I have seen is people use lifelong medicines. So I just want to know if they are affected with any other physical disease, does this medication affect the other one, or the other medicines will
May
affect
do,
this?
may do. The first part of the question is that, and I think the first part of what you mentioned is so important. People think that once they have a stent or a bypass, their disease is cured. It is not. Their problem is fixed. The disease is not cured.
Okay.
So they need to take medication lifelong to ensure that the problem doesn't come back again. Because the disease exists in their body.
Okay.
The heart disease is still there and it is controlled, treated, but not cured. Therefore, they have to take tablets lifelong. And they also need to understand healthy practices, make lifestyle changes, and follow those rigidly so that they don't get it again.
Okay.
So that is the first component. The second thing is, when you take medicine for something else, will this affect what you're taking? It might do, because a lot of things we take interact, even food interacts with medicines. But most heart drugs, most tablets taken for the heart disease, do not necessarily prevent you from taking an antibiotic or taking some other painkillers or whatever. But some of the things that I strongly recommend people not to do is to go on and buy stuff over the counter. So if another doctor is prescribing, tell them you're taking this medicines, and they will look at it and see if there is an interaction. They won't give you the interacting medicine. But instead, if you go to a medical shop and say, can you please give me something for headache or something for fever, they will absolutely know nothing about what you're taking in the first place. And even if they did know, they may not know about the interactions. So it is a very harmful thing, dangerous thing to do, to go over the counter and buy stuff and take.
So they always have to come to a doctor.
Come to a doctor, indeed.